All right, picture this. You're in a hospital facing a serious health issue, and your doctor gives you two choices for treatment. One is a less invasive procedure, maybe a stent. The other is more involved, open heart surgery. How do you even begin to choose between those options?
It's a really tough situation to be in, and it highlights the incredibly complex decisions doctors and patients face when it comes to treating heart disease.
Right, and on the deep dive, we like to unpack those complex topics, diving deep into the research and evidence to give you the knowledge you need. And today, we're doing just that, looking at a critical area in cardiac care. The choice between percutaneous coronary intervention, or PCI, that's the less invasive stuff like stents and coronary artery bypass grafting, or CABG, which is the open heart surgery option.
Both are used to treat coronary artery disease, and we're going to explore what the research tells us about the effectiveness of each procedure.
We've got a whole collection of clinical trials to look at, and we want to really understand the strengths and weaknesses of each option, not just for doctors, but for anyone who might find themselves facing these kinds of decisions.
Absolutely. Knowledge is power, as they say.
Exactly. And before we jump into the details, we want to give a huge shout out to London Heartbeat's Z Academy in the UK. They've been incredibly supportive of our educational mission here. They offer a ton of courses, over 150, on various medical topics.
Definitely worth checking out. You can find them on Facebook, Instagram, YouTube, all the usual places. They post regular updates and even some free content, so be sure to subscribe so you don't miss out.
Okay, so let's get into it. We're going to break down the results of some major clinical trials that have compared PCI and CEG. We'll start with some of the earlier research and then work our way towards more recent studies.
Sounds good. So kicking things off, we have the bypass angioplasty revascularization investigation, or BARI trial. Now, this was a big multi-center study that randomized patients to receive either CABG surgery or PTCA,
PTCA.
percutaneous transluminal coronary angioplasty. Essentially, it was a precursor to modern-day PCI, mainly using balloon angioplasty to open up blocked arteries.
So not quite the same stenting procedure that's commonly done now.
Right. Nowadays, PCI typically includes placing stents, those little mesh tubes, to help keep the arteries open for longer.
Makes sense. It's important to keep that in mind as we're looking back at these older trials. So who are the patients they enrolled in this BARI trial?
They focused on people with symptomatic coronary artery disease. That means patients who were experiencing symptoms like chest pain or angina. They also included some folks who showed signs of serious ischemia, which is a significant lack of blood flow to the heart during exercise tests.
So definitely people with some real heart problems.
Yeah, for sure. And crucially, all the participants had what's called angiographically proven stenosis.
Meaning?
It means they used medical imaging, coronary angiography specifically, to confirm that the patients had narrowing of at least 50% in one or more major arteries supplying blood to the heart.
So they were pretty sure these people needed some kind of intervention. How many patients were in the study, and when did it all happen?
BAR enrolled a total of 1,829 patients from 18 different medical centers. And this all took place from 1988 to 1991.
Wow, so this is data from a while back, but still super important to understand where things started, right?
Absolutely gives us that historical context.
Okay, so what were they trying to find out in the BARI trial? What were the big outcomes they were measuring?
Well, first and foremost, they wanted to see how many patients survived over time. So survival rates were a primary outcome. They also looked at whether patients experienced a Q-wave myocardial infarction, which is a severe type of heart attack.
Oh, wow.
Yeah, and they tracked how many folks survived without having that kind of heart attack. Beyond that, they also kept a close eye on any complications that happened while the patients were still in the hospital.
I can imagine that's pretty important with procedures like this.
Definitely. They also looked at whether any patients switched from their originally assigned treatment group, from PTCA to CIBG, or vice versa.
Makes sense. And was there anything else they were keeping track of?
Yeah, they were also looking at the rate of target vessel revascularization, or TVR.
Which is
Basically, it's the need for any repeat procedures, like another angioplasty or bypass, on the specific blood vessel that was originally treated.
Got it. So with all of that being tracked, what were the major results of the BARI trial? How did PTCA compare to CIBG?
Okay, so one of the first things they noticed was that in-hospital mortality rates were actually pretty similar between the two groups, like really close.
So in the immediate aftermath of the procedure, there wasn't a huge difference in terms of who survived.
Right. It was 1.3% for the CABG group and 1.1% for the PTCA group.
Interesting. So not a big difference there.
Nope. But here's where things get kind of interesting. They found that more patients who had CABG actually experienced a Q-wave MI, that severe heart attack, while they were in the hospital compared to the folks who had PTCA.
Hmm. That's kind of surprising, isn't it? You'd think the less invasive procedure would have a lower risk of a heart attack.
You'd think so, right? But it makes sense when you consider that CABG is a big surgery. They have to stop the heart and work on multiple vessels, which can put a lot of stress on it. So it seems that stress can sometimes lead to these kinds of heart attacks right after the surgery.
Okay, so maybe PTCA is gentler on the heart in the short term.
That's what it seems like. But a BAR trial also had this other super important finding. They found that the rate of TVR, the need for another procedure on that same artery, was way higher in the PTCA group compared to the CABG group.
Oh, wow. So even though it might be gentler initially, it might not be as effective at keeping the artery open in the long run.
Exactly. That seems to be the trade-off. They found a 6.3% rate of repeat procedures in the PTCA group versus just 0.1% in the CABG group.
That's a massive difference.
It is, and it was statistically significant, meaning it wasn't just random chance. So it seems like while PTCA might be less invasive up front, it doesn't necessarily offer the same long-term durability as CABG.
That makes sense. So kind of a balancing act then.
You got it. And we see this theme pop up again and again in these trials.
Okay, so that's BARI. What's next on our list of trials?
Next up is the CBRI trial.
CBRI.
Yeah, it stands for coronary angioplasty versus bypass revascularization investigation. As you can tell, it was also looking at the differences between CABG and PCI. And this time they had 1,054 patients.
Okay, and what was the main takeaway from CBI?
Well, it really emphasized the importance of getting complete blood flow restoration in patients with multivessel coronary disease, especially for those who also have a chronic total occlusion of a major artery.
So more than one blocked artery.
Exactly. And a chronic total occlusion means there's a complete blockage in one of those arteries, and it's been there for a while. What they found in CABRI was that if they could restore blood flow to all the blocked arteries, regardless of whether they use PCI or CABG, the patients did a lot better long term.
Interesting. So it's not so much about which technique is better overall, but more about making sure all those blockages are dealt with.
You got it. The goal of the treatment was more important than the specific method they used to achieve it.
I see. So the takeaway is that sometimes getting complete revascularization, however you do it, is the key.
Exactly.
All right, that makes a lot of sense. What's the next trial we should discuss?
Let's move on to the arterial revascularization therapy study, or ARTES trial.
ARTES. Okay. What did they look at?
This one is all about comparing stenting with CABG surgery in patients with multivessel coronary artery disease over a longer period, 5 years to be exact. So more in line with current practices.
So a more relevant comparison to what doctors are doing now. And how did they go about setting up this comparison?
They did a randomized trial, enrolled 1,245 patients, and split them into two groups. Half got CABG, half got stents.
Okay, standard procedure for these kinds of trials.
Right. And importantly, they only included patients where both CABG and stenting were considered viable options. So the doctors felt like either treatment could work for these folks.
Got it. And what were they primarily focused on measuring?
The main thing they looked at was freedom from major adverse cardiac and cerebrovascular events, or MACCE, at 1 year post-procedure.
MCCE, that's a mouthful. What does it include?
It's basically a bunch of serious events lumped together: death, stroke, heart attack, and the need for any repeat procedures.
So basically, how many people had some kind of major heart problem within a year?
Exactly. And they also looked at the 5-year MECC rate as a secondary outcome to get a sense of the longer-term picture.
Okay, so after 5 years, what did they find? Was stenting as good as CABG?
Interestingly, after 5 years, there wasn't a statistically significant difference in overall mortality between the two groups, meaning they both had pretty similar death rates.
Really? So stenting wasn't worse than surgery in terms of keeping people alive?
Not in this study, no. And they even looked specifically at diabetic patients who tend to be at higher risk, and the results were pretty much the same.
Interesting. But what about those other events, like stroke and heart attack?
They looked at that too: freedom from death, stroke, or MI, and again, there was no significant difference between the groups.
So for those major life-threatening events, stenting seemed to hold up against CABG.
Yeah, but then you've got that MACE thing, which also includes repeat procedures, and there they found a pretty big difference.
Ah, I see where this is going.
Yep, the rate of needing another procedure was way higher in the stent group. Like 30% of the stent patients needed another intervention within 5 years, compared to just under 9% in the CAB group.
That's a pretty big gap. So even though they had similar rates of death and heart attack, the stent patients were way more likely to end up back in the cath lab or the operating room.
Exactly. And when they factored in all those events together, they found that the stent group had a lower overall event-free survival rate, meaning they were more likely to have something bad happen, even if it wasn't death or a major heart attack.
Makes sense. So the bottom line with ARDS is that stenting might be comparable to CABG for preventing death, stroke, and MI, but it comes with a much higher chance of needing another procedure down the line.
You nailed it. That's the key takeaway.
And then there's ARTS II. What's the story with that one?
So ARDS II took things a step further. Instead of looking at bare metal stents, which were used in ARDS II, they focused on drug-eluting stents, or SES. These are the stents that slowly release medication to help prevent the artery from closing up again.
Oh, so a more advanced type of stent. Did they compare them directly to CABG?
Well, not directly. ARTSTAC wasn't a randomized trial. They took the results of the SES group and compared them to both the CABG and bare metal stent groups from the original ARTSTAC trial.
Oh, so like a historical comparison.
Exactly. They wanted to see if these new stents could improve on the results of bare metal stents and how they stacked up against CBG.
Makes sense. And how many patients did they have in ARTSTAC?
They enrolled 607 patients. And what they found was pretty interesting. When they looked at death, stroke, or MI combined, the SES group actually did pretty well.
So these newer stents seem to help reduce those really serious events.
Yeah, they had a rate of about 13%, which was similar to the CABG group from ARTSECO and better than the bare metal stent group.
Okay, so promising results there.
For sure. But when they looked at MCCE, things got a little more complicated.
Ah, there it is again. That MCCE always throws a wrench in things.
It does. The MCCE rate for the SES group was higher than for the CABG group, but still lower than for the bare metal stent group.
So the drug-eluting stents were better than the old stents, but still not quite as good as CABG.
Right. And one reason for this was the risk of stent thrombosis, which is basically a blood clot forming inside the stent.
Ah, right. So even though they're designed to prevent blockages, those stents can still cause problems.
Unfortunately, yes. It seems like stent thrombosis was a factor in a significant chunk of the MACCE cases in the SES group.
That's definitely something to keep in mind. So the big takeaway from ARTS II is that drug-eluting stents were a step up from bare metal stents, but they still weren't quite as good as CABG when you look at the overall picture.
Precisely. They had comparable safety in terms of the most serious events, but the higher risk of repeat procedures and stent thrombosis kept them from fully catching up to CABG.
Okay, so we're seeing some real progress, but there are still some trade-offs. Let's move on to our next study, the EAST trial.
So EAST stands for the Emory Angioplasty versus Surgery trial. This one was done at a single center, Emory University, and they were looking at the long-term outcomes of patients who got either angioplasty or bypass surgery.
Okay, so another direct comparison. How many patients were in this one?
They had 392 patients, split almost evenly between the angioplasty and surgery groups.
Got it. And what were they primarily measuring?
They were looking at the combined rate of death, heart attack, or a large area of reduced blood flow in the heart muscle at 3 years after the procedure.
So again, focusing on those big, serious outcomes.
Right. And at that 3-year mark, they found no significant difference between the two groups. But, just like we've seen before, there was a higher need for repeat procedures in the angioplasty group.
Okay, not a surprising result at this point. But EAST was all about long-term outcomes, right? Did they follow the patients for longer than 3 years?
They did. The National Heart, Lung, and Blood Institute stepped in and funded a 5-year extension. So they ended up following the patients for a total of 8 years.
Wow, that's impressive. Did they manage to keep tabs on all the patients for that long?
Remarkably, yes. They achieved a 100% follow-up rate for the patients who were still alive after 3 years.
That's amazing. So what did they find after those 8 years? Was there still no difference between the groups?
Well, the survival rate was actually slightly higher in the surgery group, but the difference wasn't statistically significant.
So basically, the long-term survival was pretty much the same, whether you got angioplasty or surgery.
That's what the data showed.
Interesting. And did they notice any differences in specific subgroups?
They did. They found that patients with blockages in a particularly important artery, the proximal left anterior descending artery, and those with diabetes seemed to do better in the long run if they had surgery. But again, this wasn't statistically significant for the whole group.
Okay, so some hints there, but not conclusive. Anything else interesting from the EAST trial?
Yeah, one really interesting thing was that after the first 3 years, the need for repeat procedures became pretty much equal between the two groups.
Really? So the gap kind of closed over time.
It did. It seems like those who needed another procedure early on got it, and then things stabilized.
That's a pretty important finding. So East is telling us that while you might need more procedures early on with angioplasty, the very long-term survival can be similar to surgery, especially if you don't have diabetes.
That's a great summary.
Okay, now let's move on to a study with a very interesting name. The AWESOME trial.
Awesome stands for angina, with extremely serious operative mortality evaluation. Catchy, right?
It is. So what were they looking at?
They were specifically looking at patients who had already had CABG surgery in the past and were having problems with angina again, chest pain that wasn't going away with medication.
Okay, so people who had already been through bypass once. That sounds like a tricky situation.
It is. Repeat CABG surgeries are much riskier than the first one, and AWESOME was the first randomized trial to include these patients.
So they wanted to see if PCI was a safer option for these folks than putting them through another bypass.
Exactly. They screened a huge number of patients, over 2,400, and they all had severe angina that wasn't responding to meds and at least one other high-risk factor, like poor heart function.
So a really sick group of people.
Yeah, definitely. And out of all those patients, they had 142 who had a previous CABG and were included in the randomized part of the trial. They also had two other groups, a physician-directed registry and a patient choice registry, which included even more patients with prior CABG.
Okay, so in the randomized trial, where they randomly assigned people to either PCI or repeat CABG, what did they find?
Well, after 3 years, there wasn't a significant difference in survival rates. It was 73% for repeat CABG and 76% for PCI.
So similar survival rates, even though repeat CABG is generally considered riskier?
Right. And the results were similar in the physician-directed registry, where doctors chose the treatment. Both groups had around 70% survival after 3 years.
Interesting. What about that patient choice registry? Did they find anything different there?
Now, this is where it gets really interesting. The survival rate for those who chose PCI after a previous CABG was significantly higher than for those who chose another bypass. It was 86% for PCI and 65% for repeat CABG.
Wow. That's a huge difference. So it seems like in this group, where patients got to choose, those who opted for PCI fared much better.
Yeah, it's pretty compelling evidence. And based on all these findings, the researchers concluded that PCI might be a better option than repeat CABG for a lot of folks who've already had bypass surgery.
That's a really valuable insight for those patients. Okay, moving on. Let's talk about the CARDia trial. This one focused on patients with diabetes, right?
You got it. CARDia stands for coronary artery revascularization and diabetes, and they were looking at whether PCI with stenting was as good as CABG for diabetic patients with multivessel coronary artery disease.
And why did they focus on diabetes specifically?
Well, historically, CABG has been the go-to treatment for diabetic patients with multivessel disease. But as PCI technology got better, they wanted to see if that was still the best approach.
So CARDia was trying to settle the debate, so to speak. How did they set up the study?
They did a randomized trial at 24 different centers, enrolling 510 diabetic patients with multivessel disease. Half got PCI with stents, half got CABG. And their primary outcome was the combined rate of death, heart attack, and stroke.
Okay, so focusing on those really big events again, and did they use the same kind of stents throughout the trial?
Actually, they started with bare metal stents, but then drug-eluting stents became available, and they switched to those. By the end, about 70% of the PCI patients got the drug-eluting stents.
So it kind of reflected the evolution of stent technology at that time.
Exactly.
So what did they find after a year? Did those new stents make a difference?
Well, the rates of death, heart attack, and stroke were pretty similar between the CABG and PCI groups, even when they looked just at the patients who got the drug-eluting stents.
Okay, so no clear winner there.
Right. But when they added the need for repeat procedures into the mix, the CABG group did significantly better.
So even with the fancy new stents, those PCI patients were still more likely to need another procedure.
Yeah, it seems like that's a pretty consistent pattern.
Okay, so CARDia tells us that for diabetic patients, PCI might not be quite as good as CABG, even with drug-eluting stents, especially when you consider the need for repeat procedures.
Precisely. And they emphasized that longer follow-up was needed to really compare these two treatments over the long haul.
All right, and we've got one more trial to discuss today, ERACI II.
The Argentine randomized trial of coronary angioplasty with stenting versus coronary bypass surgery in patients with multiple vessel disease.
A very descriptive title.
It is. And this one specifically focused on the 5-year outcomes of PCI with stenting versus CABG in patients with multivessel disease.
Okay, so a longer-term follow-up. Was there a reason they did this particular study?
Yeah, their earlier study, ERACII, had actually hinted that PCI with stents might be better than CABG after a year. So they wanted to see if that held true over a longer period.
So ERACI II was all about confirming or debunking those earlier findings.
Exactly. They enrolled 450 patients with multivessel disease and split them evenly between PCI and CAB. And they managed to follow up with 92% of the patients for the full 5 years, which is really impressive.
That's great. It gives us a lot of confidence in their results. So what did they find after 5 years? Did those initial findings hold up?
Well, the survival rates and the rates of having a heart attack were pretty much the same between the two groups.
So no difference there.
Not really.
Yeah.
But once again, there was a big difference in the need for repeat procedures. The patients who got PCI were a lot more likely to need another procedure down the line.
That's consistent with pretty much everything we've seen so far.
It is. And that difference in repeat procedures actually drove the difference in their primary outcome, which was freedom from major adverse cardiovascular events, or MBC.
So even though their survival and heart attack rates were similar, the PCI patients had a higher rate of MACCE because they needed more procedures.
Exactly. So even though those initial findings from ERACII I suggested that PCI might be better, ERACII II showed us that over 5 years, CABG actually led to better freedom from those major events, mainly because it reduced the need for repeat procedures.
Okay, so we've covered a lot of ground here looking at all these different trials. What are the big overarching takeaways? What have we learned about PCI versus CABIA?
Well, one thing that's really clear is that both PCI and CABG can be effective in treating coronary artery disease. They often have similar mortality rates, meaning they're both pretty good at keeping people alive. But the big difference seems to be the need for repeat procedures. PCI, even with the newer drug-eluting stents, just seems to lead to more re-interventions down the line.
Yeah, that's been a pretty consistent theme throughout all these trials.
It has. And we've also seen that the best approach can really vary depending on the patient. For example, for folks who've already had CABG, PCI might actually be the better option for a second go-around. And for diabetic patients, the jury's still kind of out, but it looks like CABG might have an edge.
So it's not a one-size-fits-all situation. The best treatment really depends on the individual patient and their specific circumstances.
Absolutely. Factors like the severity of the disease, other health problems, and even patient preferences all play a role in deciding the best course of action. These studies provide a ton of data, but ultimately it's a conversation between the doctor and the patient to figure out what makes the most sense for them.
And it's a conversation that's constantly evolving as technology changes and we get more data. It makes you wonder what the future holds for these procedures. What new things will doctors and patients have to consider when making these decisions?
That's a great question. I think we'll continue to see incredible advancements in both PCI and CABG. New stent technologies, less invasive surgical techniques, and better medications are all on the horizon. And I think genetics and biomarkers will play a bigger role in helping us predict which patients will do best with which procedure.
So even more personalized medicine.
Exactly. It's all about finding the best treatment for each individual patient. And these clinical trials will continue to be essential in helping us understand how to do that.
This has been an incredible deep dive into the world of PCI and CABG. We've learned a lot from these trials, but the conversation doesn't end here. If you're facing these decisions yourself, talk to your doctor, ask questions, and be an active participant in your healthcare.
Couldn't agree more.
And if you want to learn more about these trials or explore the research yourself, we encourage you to check out the citations and links we've provided.
There's a wealth of information out there for those who want to dive even deeper.
Thanks for joining us on the deep dive. We'll see you next time.